delivering quality healthcare in crisis, supporting migrant and refugee populations from Ukraine. Guidance from the WHO Global Competency Standards for health workers. Why do we need targeted approaches to the health of refugees and migrants? Strong health systems are sensitive to the needs of refugees and migrants, their languages, and their unique health problems. Refugees and migrants may have specific health needs and vulnerabilities that require culturally sensitive, effective, and high-quality care that also recognises the impact of migration on physical and mental health. At no point is this more crucial than in situations of recent displacement and crisis, as is the current situation in Ukraine and in the countries across Europe receiving large inflows of refugees from Ukraine. What are the Global Competency Standards? The World Health Organization's Refugee and Migrant Health Global Competency Standards for health workers highlight a range of competencies and behaviours to help health workers provide culturally sensitive care to refugees and migrants. We know that competencies change with time, experience, and setting. In this video, we will adapt the standards to the unique settings of the Ukrainian refugee situation. Why are the standards important? Refugees and migrants may face a number of challenges to accessing healthcare, including language and cultural differences, institutional discrimination, and restricted use of health services. Health workers have a vital role in providing people-centred health services and building the resilience of health systems to respond to the health needs of refugees and migrants. However, health workers seeking to provide quality care may face a range of operational and clinical challenges. The purpose of this video is to support health workers by demonstrating how the Global Competency Standards can be adapted and applied in real settings. In this case, to 6 case studies reflecting common health problems experienced by people fleeing Ukraine. We will consider impact of displacement and disrupted treatment, eligibility and access to local mainstream health systems for refugees, language concordance between practitioner and patient, particular risks of vulnerable groups, including deteriorating mental health, trafficking, and sexual and gender-based violence, and health practitioner decision-making in challenging and dynamic environments. We will identify key considerations and learning points for health workers with respect to each of the competency standards for health workers. There are 9 competency standards spread across 5 different domains, and each is illustrated by specific health worker behaviours. Under the domain of people-centeredness, health workers 1. Provide people-centered healthcare to refugees and migrants, and 2. Promote the agency of refugees and migrants at individual and community levels. Under the domain of communication, health workers 3. Engage safe and appropriate aids to meet language and communication needs of refugees and migrants. And 4. Support refugees and migrants to understand information about their healthcare. The third domain is collaboration. Here, health workers 5. Engage in collaborative practice to promote the health of refugees and migrants, and 6. Respond to migration and displacement-related surges in demand for services. Within the domain of evidence-informed practice, health workers 7. Promote evidence-informed healthcare for refugees and migrants. The final domain is personal conduct. Competency standards guide health workers to 8. Engage in lifelong learning and reflective practice to promote the health of refugees and migrants. And 9. Contribute to a culture of self-care and mutual support when providing healthcare in the context of migration and displacement. So what do these competency standards and behaviours look like in practice? Let's think through in relation to the 6 case studies depicting the situation of refugees who have recently been displaced from Ukraine into neighbouring countries or further into Europe. In each case study, health workers respond with particular behaviours that demonstrate the global competency standards in action. Case Study 1. Irina and Victor. Irina, aged 44, comes to the clinic with her father Victor, aged 68. Victor brings with him a handwritten outline of his medications, written in Cyrillic. His daughter, who speaks Russian, indicates to the clinic staff that Victor has to take his medicines every day. Using an online translation tool, you work out that the medications are rifampicin, ethambutol, pyrazinamide, and levofloxacin. What condition does Victor have? Why did Irina and Victor not communicate this directly to the clinic staff? You recognise that this is a tuberculosis treatment regimen, probably for isoniazid-resistant TB, even though Irina and Victor have not said this. Thinking about Competency Standard 1.1 on giving consideration to the impact of migration and displacement experiences on the needs of the person, you're not sure if their reticence to communicate is due to communication challenges, concerns about negative perceptions of TB, or distrust of the health service. Seeking to mitigate language and communication barriers, as suggested in Competency Standard 3.2, you take the pair into a more private area with a bilingual health assistant to interpret. Victor says he is worried that his pulmonary tuberculosis may impact on whether they will be able to find accommodation. Upon further questioning through the interpreter, Irina says that Victor ran out of medication a week ago. He had previously been on a directed, observed treatment regime for 2 months, but when the conflict became more dangerous, the clinic had given him enough medication for 2 weeks. What are the major management concerns at this stage? Tuberculosis treatment. Victor has not had his medication for 1 week. If he does not get continuity of his medications, there is risk of developing multi-drug resistant tuberculosis. You will need to arrange urgent continuation of medications, bearing in mind that Victor does not have resources to buy the medications himself. As considered in Competency Standard 1.4 on universal access to quality healthcare, this will probably involve exploration of Victor's access to publicly funded medications as a refugee, and a discussion with the local public health or TB treatment unit. Contact assessment. Irina is at risk of contracting tuberculosis. She says that she has been tested in Ukraine, but she has no documents, and the clinic has been closed due to the conflict. Thinking about Competency Standard 7.1 regarding use of evidence-informed guidelines, you recognise that Irina needs to be assessed as a contact to see if she too has contracted tuberculosis. Safety and discrimination. Victor and Irina are worried about discrimination if Victor is known to have tuberculosis. He is no longer coughing. You're aware that under your country's notification of infectious diseases rules, you will need to notify this case, but you assure him that this will be confidential. Assuming that he is stable on his medications and his condition is suppressed, he has already had 2 months of treatment with a planned treatment course of 6 months. You explain that he should be able to continue his treatment in the community for a further 6 months with his confidentiality preserved. This is important for ensuring he understands information about his healthcare, as in Competency Standard 4.1. Further migration. If Irina and Victor are travelling further, plans need to be made to ensure sufficient provisions of medication as they transit to a third country. He also needs to have clear documentation of his medication history and plan for ongoing treatment. This is about facilitating continuity of care by supporting people to hold their own health information, as articulated in Competency Standard 1.5. Case Study 2. Olga. Olga is a 65-year-old woman who comes in for a checkup of her diabetes and high blood pressure. She takes an injection of insulin every day and takes some other medications that she can't remember. She has brought some of the boxes with her and some sheets of medication. The box indicates that the insulin is glargine. Thinking about Competency Standard 2.1 on assessing health literacy, you note that Olga is not sure of the dose she used to take, as her son, now in the army, used to draw it up for her. She shows you 3 different sheets of tablets. You can see on the back that the medications are metformin, glibenclamide, and ramipril. She has lost her glucometer. She would also like you to prescribe a sleeping tablet. As a newly arrived refugee, Olga has been given accommodation nearby in a billet with another older lady. You are able to communicate with her with the help of Katrina, a nursing student from Ukraine who is part of your team. With Katrina's help, you utilize the skills of health workers from refugee backgrounds, as advised by Competency Standard 5.3. You check Olga's blood sugar level with the clinic glucometer. Her BSL is 342 milligrams per deciliter, or 19 millimole per litre. She has no ketones in her urine. In addition to being thirsty, she feels tired and begins to cry as you talk to her. So, what are your priorities for Olga? Sensitive and supportive care. Olga is distressed and unwell. Bearing in mind her age, gender, and experience of displacement, as in Competency Standard 1.2, your investigation of her clinical situation needs to be accomplished gently without further traumatizing her. Katrina provides calm and capable support. Safety. The treatment regimen indicates that Olga has type 2 diabetes, which has been unstable enough to require long-acting insulin in addition to medical tablets. You have no insight into how stable Olga's diabetic control is on her current medication. As in Competency Standard 7.1 on using evidence-informed guidelines and standards, your prescribing must take into account risks of causing hypoglycemia and the fact that Olga is inexperienced at giving insulin. Supporting self-management. Olga is going to have to rely on herself to manage her diabetes, and she needs to have a written outline of her medications and be confident administering them. In order to support her to develop her health literacy, as Competency Standard 2.2 advises, Olga needs some careful reinitiation of her diabetes medications, starting with the oral medications. If she lives nearby, she can return for some training on how to give herself her glargine injection and how to monitor her own diabetes. She should purchase a glucometer to monitor diabetes. If she is unable to do this, it would be useful to refer her to a support service with resources to assist in purchasing a glucometer. This would be a demonstration of Competency Standard 5.4 regarding effective engagement with other health service stakeholders to provide integrated and coordinated care. But what is your response to Olga's request for a sleeping tablet? Aware of Competency Standards 1.3 and 2.7 on providing trauma-informed care and recognizing the impacts of family separation, you note that Olga's history suggests that she has experienced many difficult and distressing experiences. Her son is no longer with her. She has left her home and appears to have no family or friends with her. She tells you that she can't sleep because she keeps waking up with a sense that she can hear artillery fire. The lady she is billeted with has taken to shouting at her at night because she disturbs her sleep. You discuss the mental impacts of her difficult flight from her hometown and her fears, and she agrees to see a psychologist at a local service for refugees. After this consultation, Katrina spends a few minutes reflecting on the case with you, noting that it had not been easy for her, as Olga reminded her of her grandmother, who was still in eastern Ukraine. This debrief contributes to a supportive team environment in managing health and well-being impacts for health practitioners, as recommended in Competency Standard 9.2. Case Study 3. Solomir. 50 people have recently arrived after fleeing the conflict in Ukraine. One of them is Solomir, a 30-year-old woman who is 35 weeks pregnant. She has 2 children, aged 3 and 5. She has come from Ukraine with her sister, who has an 8-year-old son. Her husband is still in Ukraine, in the military. Conversations are challenging as they are conducted in English, the second language for all of you. Solomir is worried that she hasn't felt the baby move for 6 hours. You note that she has a raised blood pressure of 148/110. You can locate a heartbeat on a Doppler. She is not taking any medication. They are all living in temporary accommodation in a train station. Solomir is among 30 people who have come to the clinic this morning. Recognizing that there was going to be a need for extra staff, your manager has asked for 2 nurses and a doctor to be transferred from a cardiac rehabilitation clinic. None of you has previously worked together. What are your immediate priorities? The immediate priority is assessing the fetus and protection of the mother who has high blood pressure. Since you are the more experienced person in the clinic, you allocate the 2 extra nurses to lower acuity cases and ask the doctor to help you with Solomir. This relates to Competency Standard 6.1 on responding flexibly and collaboratively to surges in demand. Solomir has some protein in her urine. You can hear the fetal heartbeat with a Doppler. You advise Solomir that she should be transferred to the hospital for advice on her blood pressure. Solomir is not willing to do this, as she feels reassured that she has now heard the heartbeat and wants to go back to her children. She proposes instead to come back tomorrow or the next day for an assessment at your clinic. What would you do next? Solomir's reluctance to go to hospital should be explored, as suggested by Competency Standard 8.3 regarding awareness of intersections of systems and structure of power that may impact access and experience of healthcare. Solomir may be worried about costs of treatment or the management of the children. She may not trust the local hospital and be planning to travel onto a larger hospital. She may be psychologically overwhelmed by recent events and reluctant to make major medical decisions on the spur of the moment. All these conversations are made easier when you contact an interpreter on the telephone to help with communication, in line with Standard 3.4 on adapting practice to work effectively with interpreters and cultural mediators. Solomir decides to discuss it with her sister, who is adamant that she should go to hospital. She is concerned about costs of the medication and hospital care, and was unaware that in this health system, management of delivery and postnatal care is free to all. In this case, identifying opportunities for safe and appropriate engagement with family to facilitate provision of healthcare proves effective, as in Competency Standard 2.6. You arrange transfer after briefing the hospital about Solomir and providing her with a summary of the medical history to support effective handover of care, as described in Competency Standard 5.2. Solomir went into labour shortly after arriving and rather rapidly delivered a healthy boy. Her blood pressure returned to normal over the next month. Case Study 4. Kostya. Kostya is a 7-year-old boy who was brought into the clinic with a history of episodic shortness of breath, worse at night. His aunt Ilyana, who accompanied him on the train coming from Ukraine, says that Kostya has a history of asthma and that his shortness of breath seemed to start on the train, which she describes as crowded and smoky. Kostya's mother, father and younger brother were killed when their building was bombed. Kostya was out with his aunt when the bombing occurred. You bear in mind Competency Standard 1.1 and 2.7 on adapting practice to needs in view of displacement and recognising the impacts of family separation on health and mental health. On examination, Kostya's respiratory and cardiovascular results are normal. What would you do next? Kostya may be suffering from asthma or anxiety or both. If there is a history of Kostya being treated with an asthma reliever puffer, such as salbutamol, it would be prudent to provide this again with a spacer device, double-checking Kostya's technique and ensuring Ileana knows how to use the spacer and puffer devices. This is in line with Competency Standard 7.1 on using evidence-informed guidelines. Ileana agrees with you privately that Kostya is sad and has nightmares at night. He sleeps in the same bed as his aunt. A week later, Kostya is brought in by his aunt, gasping for breath. As the treating nurse, you gently hold Kostya and another nurse puts an oxygen mask on him. Ileana goes to the front desk to do some paperwork. Kostya throws himself screaming after his aunt, tearing off his oxygen mask. What would you do in this setting? Kostya is not in acute respiratory distress, and the assessment indicated that he was having an acute panic attack. Kostya and his aunt were moved to a quieter part of the emergency department, while Ileana gently talked him through the panic attack with your support. An example of engaging family in care, as outlined in Competency Standard 2.6. Over the next months, Kostya's distress about his loss increased. To address mental health needs, as in Competency Standard 1.3, after the first panic attack, he and Ileana were referred to the local tertiary mental health service to help with managing intrusive panic and to assist in acknowledging their grief and loss. Case Study 5. Petro. Petro, aged 78, has diagnosed prostate cancer with secondary cancer in his lumbar spine. He had been receiving palliative care prior to his forced displacement from Ukraine. He had not wanted to be evacuated as he thought he should die in his home. His son and daughter-in-law, both in their late 50s, had insisted that he come with them when they travelled to the border. He is brought in to see you the day they cross the border, because he is in a great deal of pain. He had previously been taking intermittent oral morphine, but no longer had this medication. He is brought in a wheelchair. His son, who is fluent in your language, says that his father could previously use a walking frame, but can now only manage in the wheelchair. He spends most of the day in the chair and sometimes sleeps in it at night. What are your priorities? Pain relief and support for palliative care. The major need for him at the moment is comfort. Fortunately, the family have brought his medical records, and you are able to re-prescribe the medication that he had been using in small amounts. You will need to follow existing policies used in your health jurisdiction on prescribing opiates. Thinking about Competency Standard 1.2 on adapting practice to individual characteristics of refugees and migrants, you will need to find out Petro's views on his preferred approach to managing his dying, especially as it is now occurring in another country and with care workers speaking a language he is not familiar with. Safety. The family will need support to manage his transfers in and out of the chair, to prevent falls and pressure sores. This is highlighted in Competency Standard 2.6 regarding appropriate engagement of family to facilitate care. What happens next? Petro decides to travel with the family to Germany. You note that there are few guidelines about how to manage palliative care for people on the move. and decide to spend some time thinking about how existing guidelines might apply. Competency Standards 7.2 and 7.3 are relevant here, and consider how health needs of refugees and migrants may differ from the general population and require additional evidence to determine appropriate responses. Petro is provided with some opiates for pain relief. To support effective handover of care to other health workers, as outlined in Competency Standard 5.2, an introductory letter from the clinic is provided to the family for use when crossing borders, in view of the medications he is carrying. His family are also trained in techniques to prevent pressure sores from developing. Case Study 6. Veronica. Veronica, aged 19 years, has travelled from Ukraine by herself. She stated that she had witnessed family members being shot and had managed to escape by hitching a lift with some people from her village. Veronica presented to the clinic about a week after crossing the Ukrainian border, requesting a medical termination. She is confirmed to be pregnant on a urine pregnancy test and is probably about 5 weeks along. You consider carefully Veronica's specific needs as a recently displaced woman, as reflected in Competency Standard 1.2. What would you do next? You are aware that it is possible Veronica has become pregnant through an assault. She has expressed a desire for a termination of pregnancy. Your advice will be guided by the legislation regarding abortion in the country, and this must be clearly explained to her, including options in other countries. This assists to ensure Veronica understands information about her healthcare, as in Competency Standard 4.1. It would be prudent to perform a gynecological examination to assess for infection or injury. Veronica agrees to have a gynecological examination, which you perform gently with a female chaperone beside her. She has significant bruising around the perineum and other evidence of assault. Veronica does not want to talk about the assault, but asks that you write down detailed notes of the examination. Should you seek more details about the assault? Only if Veronica wishes to disclose further to you. As per Competency Standard 7.2, you know that her own priorities should be recognised and responded to, and her options for counselling and for seeking reproductive healthcare should be supported where possible. As a young single woman, she is at risk of being trafficked, and her options and safety should be discussed with her. You decide to offer her support to access a mental health service. You also provide arrangements for the termination as requested by her. Finally, you refer her for support to continue her education, as recommended by Competency Standard 5.1 on engaging broader social and community support to address factors which influence overall health. These case studies have highlighted the complex healthcare needs of people on the move, as well as the challenging and dynamic contexts in which health practitioners provide care to refugees and migrants. The WHO's Global Competency Standards is a valuable resource to assist health workers not only to identify vulnerabilities experienced by refugees and migrants when accessing health services, but also to recognise that the empowerment and agency of refugee and migrant populations in healthcare remain critical. This is the case in the Ukraine refugee situation, as elsewhere. For further information, the Refugee and Migrant Health Global Competency Standards for Health Workers and its accompanying curriculum and knowledge guides can be accessed via the World Health Organization website.